Good morning, everybody. Project Echo Cardiology, month of January in snowy Reno. So happy winter. I hope everyone's having fun out there. We have anti-platelet and anticoagulant therapy for today. And then we'll go back to the basics of rate rhythm axis, doing rated intervals on EKGs today and working through all that. I will say that the reason why I made this talk was I was seeing a patient, kind of in a rural area, and she had come in with, come into one of the medical centers in Reno and had a really bad non-ST elevation MI. And she was in cardiogenic shock and had this high-risk stenting and all these other things done. And I came down to see her, and she was off of her antiplatelet therapy. And I said, you know, if you clot your stents, you're dead. And so, you know, the impetus here really is the critical importance of those kinds of situations, which for us really are, I mean, when you have somebody die in the hospital, it certainly strengthens your resolve. And furthermore, there's so many angles on bleeding and blood thinners and balancing all that, especially when you're caught in the middle. For any of us, cardiology or primary care, really it's important to know what benefit you're getting out of blood thinners so that you can balance that against the risk of bleeding, as we often see. So with that introduction, I definitely want to take a little time, if anyone has cases to present or discussion points outside of the talk points, give an opportunity. So if you want to unmute yourself or send in a little text, we will take those at any time.
Yeah, Nikki or Alice, any questions or cases you want to start us off with this morning?
Very good. Well,
Nikki, do you have something? Oh, go ahead.
No, it's good.
Okay,
great.
Thanks.
Excellent. And Charmaine brought us some EKGs as usual, which I always appreciate to highlight that point, my EKG talk when we get there. So let's start with antiplatelet and anti-thrombotic therapy. Yep, there we go. And so we'll split the talk into initially anti-thrombotic, then antiplatelet, and then combination therapy. And again, with the sort of progressive reaching indications for all of these things. So the most common situation that I get into anti-thrombotic therapy in is stroke prevention with atrial fibrillation. And so it's very important to define the risk of stroke and discuss this with patients, defined by the CHADS-2 VASC score. If you remember, not that long ago, maybe 5-10 years ago, we were primarily using the CHADS-2 score. The CHADS-2 score would be congestive heart failure, hypertension, age, diabetes, and previous stroke. And so people who had a CHADS-2 score of 0, we weren't really sure if they should be on antiplatelet or antithrombotic therapy. And we knew that female gender and vascular comorbidities, that would be previous heart attack, obstructive coronary disease, or peripheral artery disease, were also risk factors for stroke. And so we felt like there were probably some CHADS-2 score people around 0, maybe 1 that we were missing. And that sort of brought these other risk factors out. And so now we use the CHADS-2 VASC calculator. So you get a point for all the things that we mentioned: heart failure, high blood pressure, age over 65 is 1 point, age over 75 is 2 points, diabetes, stroke or a TIA is 2 points, vascular disease, as I said, is coronary or peripheral artery disease in female gender. So when you're counting your points, you're going to have about 1% increase in risk per point up to about 4. And then after that, you're going to have about a 1.5 or 2% jump. Generally say about 1.5 after that. So, and then strangely, the high end of the risk of the CHADS2 VASC is about 15. When we had CHADS2 is about 20. And then you have to balance that, of course, against the risk of bleeding. So hypertension, abnormal liver renal function, previous stroke bleeding. There are a lot of very similar risk factors for bleeding and stroke. And I will just say that in 2018, what we see in the cardiology literature, if you look at database studies of what clinicians are doing out there, is that most patients are undertreated for stroke comorbidities with the concern for risk of bleeding. When I did my AFib talk last month, I emphasized that you have to fall over 200 times a year, close to 300 times a year, before the risk of intracranial hemorrhage outweighs the risk of stroke. So that's a really important point. Most of these people are treated with antiplatelet therapy, and so that's what the data shows, but I will tell you anecdotally that in my practice, it's mostly the patients. Patients don't really, the idea of being on a blood thinner is overwhelming, and people don't want to do it. And until you have a stroke, the issue of risk is all theoretical. But when you're on a blood thinner and you're getting increased senile purpura, and you've got nosebleeds and all these other nuisance bleeding issues, of course you don't want to take it. But we know that it's tremendously effective. And when I ran in the hospital and see people stop their blood thinners and have strokes, it strengthens my personal resolve to continue that battle. So we have 3 main oral anticoagulants that are direct oral anticoagulants, having replaced, being alternatives to Coumadin. There's also edoxaban, which maybe some people are using. We thought that edoxaban would be a good answer for low cost, and at least in my experience, that hasn't necessarily been the case. So for prevention of stroke with atrial fibrillation, if you're using Pradaxa, which is a direct thrombin inhibitor and has a commercially available reversal agent that's been studied and is broadly available. All of them have reversal agents, but this is for sure broadly available, including at our medical center. Then if their creatinine clearance is above 30, you use 150 milligrams. If it's below 30, but they're not on dialysis, then you use 75. For Xarelto, the creatinine clearance cutoff is 50. And if their creatinine clearance or GFR is above 50, then you use 20 milligrams. And if it's below, then you use 15. So that's for Xarelto, which is 15 or 20 milligrams taken at night, and I'll explain why it's nightly dosing in just a bit. Eliquis, or apixaban, also a direct 10A inhibitor, is dosed, it's as simple as ABC is what I tell the residents. So age, body mass, creatinine. And so if you have 2 out of 3, if your age is over 80, if your body mass is less than or equal to 60 kilograms, or if your serum creatinine is above 1.5, then you drop down to the 2.5 milligram dosage, and it's twice daily. And then if you don't have 2 out of 3, you have 0 or 1 out of 3, then you use 5 milligrams twice a day. So, okay. So the other indication that's very common for the use of anticoagulants is a DVT or a PE. And so for Pradaxa, the dose is the same. For Xarelto, you're going to use 15 milligrams twice a day for 21 days. And then you go back to the 15 or 20 milligram strength. So sometimes I will see this if people aren't aware of the dosing, that they've left people on 15 twice a day for 3 or 6 months and not just 3 weeks. So again, I think, we're all here to make ourselves better clinicians. And of course, if you have any questions, then you can go on your smartphone these days and easily find the dosing. But as an alternative, the slides of this lecture, of course, will be posted, and you can access it that way. For Eliquis or apixaban, the dose is 10 milligrams twice a day for a week. Then you go back to either 5 twice a day or 2.5 twice a day. So sometimes my choice of agent will be a little bit dependent on the person that I'm looking at. So, I saw a very nice, thin 90-year-old woman recently who came in rapid AFib and a little heart failure, and I figured that I may need to have a rhythm control strategy for atrial fibrillation, but she had a normal creatinine. But of course she has, all the little old ladies are the ones who are going to bleed if anybody bleeds with these blood thinners. And so I'm always very careful, and especially she's 90 and you have to take all these things into consideration. And so if I gave her Xarelto for the convenience of once daily dosing, then she really should be 20 milligrams because she has totally normally functioning kidneys. But in that situation, I chose Eliquis because, she probably should be on a lower dose of blood thinner, and then you don't have to have some pharmacist who just is looking black and white at this picture give you a call and say, hey, you're deliberately underdosing this patient. You say, yes, I know, but it's the right thing to do. So you can, the way that you approach the agents may be varied based on the patient in front of you. Always should be varied based on the patient in front of you. I will say also that when Pradaxa has a little bit fallen out of favor with cardiologists just because a moderate amount of people will have dyspepsia with it. And again, if you're arguing theoretical risk against real side effects, the more real side effects you throw at people, the more they're apt to just say, enough with the blood thinners, give me an aspirin, and then of course their stroke risk is substantially higher. But that being said, Pradaxa has very good stroke prevention, does have a little more GI bleeding, and I'll go through all of the individual trials that brought these agents to light in coming slides. So all of these agents are at least partially metabolized by the cytochrome P450 system, but they're absorbed from the PGP receptor in the intestinal mucosa. And so what's important to know about that is that especially in the case of rivaroxaban or Xarelto, that the bioavailability of the drug is extremely variable with food. And so if you give it without food, if the patient's fasting or something, it's about 66% bioavailable. But if you give it with food, it's over 80% bioavailable. The other agents don't have that type of difference in their mechanism. So Xarelto is given with dinner. You can give it in the morning with breakfast, but it's generally given with dinner because it's more bioavailable. And so they all then have a little bit of balanced metabolism between liver and kidneys, and you can take advantage of that. Pradaxa seems to be relatively more excreted renally. But those are some of the other guiding properties to keep in mind when you dose these agents. So there you go, food. Okay, so now, although, for those clinicians of us who have used warfarin a fair amount, we know that there's just myriad drug interactions, just a ton of them. And there are many fewer drug interactions with the newer agents, but there are some. And so some to keep in mind are, for example, if you put your patient on the antiarrhythmic Multac, and you're using that in combination with Pradaxa or Edoxaban, then you have to be quite careful because those they may amplify each other. The main ones to keep in mind really are the azole antifungals. And as you can see, kind of across the board, they do increase the relative effective dosing of almost all the oral anticoagulants. The protease inhibitors increase the bioavailability of Xarelto, and rifamycin does modulate somewhat most of the oral anticoagulants. Probably the main one that we get into on a day-to-day basis is the combination of verapamil and Pradaxa, for example. And that would, you should reduce the dose in that situation. So, okay, so the RELY trial compared Pradaxa or dabigatran to warfarin, and there was a little less bleeding just in general, as you can see at the bottom of this box and whisker plot. Again, the box and whisker plot has a line around unity, and anything to either side of the line will tell you which therapy is better one way or the other, with the average effect in the box and the 95% confidence interval in the whisker. So overall bleeding was actually less with dabigatran, which is generally true of all the agents, but major GI bleeding was not less. And so, that's one thing to take in mind. Again, these are reversible. The reversal agents are a bit expensive and things like that. But Pradaxa is very good therapy, and it did have a slightly improved risk of, when you compare stroke, there was less stroke with Pradaxa. I'm sorry, there was significantly less. See, the line does not, the 95% interval doesn't cross unity with Pradaxa compared to warfarin. So there is less stroke with Pradaxa. There's a trend towards less stroke with all of them. And there seemed to be, about the same amount of bleeding by the ROCKET trial, which compared rivaroxaban or Xarelto with warfarin. But the post-marketing stuff seems to indicate that all of these agents are a bit better. And remember, in these clinical trials, they're very carefully, tightly controlled INR levels. So it's a kind of a select group of good time and therapeutic range warfarin people. So it does appear that there is less bleeding with all of them now. Aristotle looked at Eliquis or apixaban and warfarin, and there was both less stroke and less bleeding. And so Eliquis is, very common. Most people these days are using Eliquis and Xarelto, some Pradaxa, some edoxaban, and some warfarin. And most of the time we fall on warfarin because of cost. But they're better medicines. I had a case of a patient who had come in and for whatever reason, I don't honestly remember, we did a transesophageal echocardiogram. They had had an ablation procedure for atrial fibrillation and then kind of got lost to the cardiology service. This was at least 5 or 6 years ago. And this patient had a big thrombus in the left atrial appendage. And it turned out that they had been taken off of their Eliquis. And then they had spine surgery, which of course is a tremendously procoagulant state. And that was right in the aftermath of having a scar line on their left atrial appendage. So they were like the perfect setup for having a blood clot after. I don't know why the spine surgeons never talked to us in that situation. But there was for a time this thought that there was this rebound prothrombotic effect when you would stop Eliquis. And I'll say that I've interrupted Eliquis 1,000 times since then. And I've not seen anything similar to that. So the original black box warning has been discounted. So if anybody remembers all that rigmarole, that's no longer a thing, bottom Okay, so that's anti-thrombotic therapy. And so now we'll get into anti-platelet therapy, and then we'll put them together and make people really bleed, as we often do. So if you'll recall my lecture on non-ST elevation and ST elevation acute coronary syndrome, the critical mechanism is the rupture of this atherosclerotic plaque and clot formation. And as I will highlight, the component of platelets in that clot plug is critical, and uncoupling that is extremely important in managing acute coronary syndrome to wash that clot out and get blood flow back to the heart muscle in a timely manner such that you can limit the size of the infarction. And so this is an electron micrograph of an activated platelet. A deactivated platelet is nice and smooth, but these guys get all these spiny fingers. I tell patients that when platelets become activated, they become spiny like a porcupine. And this picture highlights that phenomenon. I also tell them that smoking causes this to happen without any other prothrombotic milieu in the vascular endothelium. But typically, what happens to activate the platelet to get those funny looking fingers is exposure to collagen, ADP, and other procoagulants. This ADP is critically important. It reacts with a receptor in addition to thromboxane A2, thrombin, collagen, and a few other things. But this ADP receptor is especially potent in activating a platelet to develop that spiny architecture such that it's very sticky to the vascular endothelium, helping to propagate a clot, and also releasing more ADP to activate other platelets. So it's very, very important in the prothrombotic milieu, this ADP receptor. It's central. And on that ADP receptor is a specific part of the receptor, the P2Y12. And that P2Y12 portion of the ADP receptor is the target for therapy that we use with all of our modern antiplatelet therapies. And so again, sticky platelets come down here and are woven into this fibrin mesh that happens in the blood clot cascade. And of course, the thrombin fibrin portion is affected by anti-thrombotic therapy, and the platelet portion by antiplatelet therapy, and they interact with each other. So there's some overlap there. Again, this highlights the sort of central importance of degranulation of these ADP-containing granules, stimulation of the P2Y12 receptor, and propagation of the thrombus. So that explains a little bit of why these are such potent therapies. So there's three main antiplatelet therapies that we use these days, and those include Plavix or clopidogrel, ticagrelor or prasugrel, or ticagrelor or Brilinta, or Effient or prasugrel. So Plavix, Effient, Brilinta. So Plavix and Effient all are absorbed through the gut, and then they are prodrugs. Those two are prodrugs that are metabolized by the cytochrome P450 system into their active metabolites, which are the things that inhibit the P2Y12 receptor on the ADP receptor on the platelets. Ticagrelor is unique in that there's no biotransformation via the cytochrome P450 system in order to create that active drug to inhibit the P2Y12 receptor. But both Effient and Brilinta have mortality benefit over Plavix in acute coronary syndrome. So they're better medicines, they're more expensive medicines. and all these things. So these are the things that we have to juggle when we're balancing patient benefit and effectiveness of medicine and cost, which we're always doing for all of our patients, hopefully all of the time. And as you can see, when it comes to these P2Y12 receptors and the treatment of, in this case, non-ST elevation acute coronary syndrome, it's a class 1 level of evidence B indication for the use of these agents, either Plavix, ticagrelor, or prasugrel. They're all in there, and they're all very good agents for helping people live through a heart attack. So, Plavix or ticagrelor. So here's the original study that shows the effectiveness of Plavix over placebo, and this really transformed, I think, a lot of the care of acute coronary syndrome. This was published 18 years ago now, almost. So that's pretty amazing that it's been that long, but I guess it has. This is the Cure trial, and essentially comparing Plavix to placebo, there's less death, heart attack, death from cardiovascular causes, non-MI, or stroke, up to 12 months after a heart attack. So a lot of times, at least some of the time, somebody will have a heart attack, and remember, mass heart's like a football, 3 main arteries. One goes down the seams, that's the left anterior descending, LAD. 2 go around the sides. Around the left side is the circumflex, around the right side is the right coronary artery. And the right coronary artery tends to be quite large if it's a dominant system. And sometimes, if you have a really large right coronary artery, you'll get a bare metal stent because it's no different at about 4 or 4.5 millimeters in diameter. There's no real increased risk of thrombosis comparing bare metal to drug-eluting stents, related to which, if they get a bare metal stent, they theoretically can come off of their antiplatelet therapy as early as 3 months later. But if they had a heart attack, non-ST elevation MI or an ST elevation myocardial infarction, and they got stents or bypass, they still benefit from antiplatelet therapy for an entire year. And so in those situations, if there's not a contraindication or I'm not juggling other things, I keep them on that therapy for a year. It's not to keep, in the case of a bare metal stent or bypass grafts, their grafts or stents open. It's for prevention of another heart attack, because if there's one 70% lesion in the coronary tree, there's all these other 20% lesions, and the collective risk of one of those 20% lesions rupturing is more than the 70% lesion. And even if you've got that graft around that lesion, some of that high-grade atherosclerosis could still rupture and go downstream. So you want to de-inflame that coronary tree for about that period of time to achieve maximum benefit in terms of event rates. And that's why we use it for a year. Grafts, bare metal stents, drug-eluting stents, or nothing, unless there's a clear reason to stop. The most common, the most potent way to thrombose that stent, if you look at any other risk factors, is stopping your dual antiplatelet therapy. And so this is a collection of trials that basically shows that if you stop your antiplatelet therapy, that you'll have increased risk of stents. This next is a little bit better. This shows all the risk factors for stent thrombosis. And if you look at the relative risk of stopping your antiplatelet therapy, that's about 15 times or 1,500% higher if you stop antiplatelet therapy before 1 year. So really, probably some of the best studies show that it's just tremendously, risky. And that risk, if you look at it in a year, will go down exponentially. So the highest risk is in the first 1 to 3 months, but there's still persistent risk that sort of flatlines out towards a year. So those are some of the principles. If we do need to take a high risk, that we invoke deciding which way to go and counseling patients on, frankly, very difficult choices. Some of the coronary anatomy really matters in terms of the risk of in-stent thrombosis. So we took sort of everyone at large as far as risks of in-stent thrombosis, but there are certainly some people who have more high-risk stenting that would be at higher risk for stent thrombosis. Obviously, if they already had stent thrombosis, then they're tremendously high risk. But it behooves us all to understand the coronary anatomy and what was done in the cath lab on the day of their heart attack or after investigation and they required stenting. So if they have, let's say you have an LAD and a diagonal and you need to do bifurcation stenting, that is a risk for stent thrombosis. If you have a very eccentric stenosis versus a sort of candy wrapper stenosis, that's a risk. If you use a big layer, a long, area of artery that you stent more than 26 or 30 millimeters, that's a risk for stent thrombosis. We used to call that a full metal jacket. Maybe we still do. When they get, basically the artery stented stem to stern. And of course, it's not good. And because you lose your endothelial tone, but also because you have a very much higher risk for stent thrombosis. And then if the artery is tortuous, of course, that it's going to still be pulsating with blood. And as it pulsates, that stent that's crossing that tortuosity is much more likely to fracture and then thrombose. So when you're thinking about these things, if you're in a rocky circumstance and there's a high risk of stopping dual antiplatelet therapy, but maybe somebody needs an emergent surgery for whatever reason, they have a hip fracture that's displaced and they need that thing to get fixed, and the orthopedic surgeon says, we really need to stop this dual antiplatelet therapy, those types of stents should sort of ring alarm bells as far as the risk of that type of thing. So here's some pictures. And again, here's a bifurcation stent. So here's a stent that was placed in the left circumflex coronary artery and then the obtuse marginal coronary artery. And you can see that, this portion of the stent is fractured. Because a lot of times you'll go through a stent strut to get that other stent in and all these things. And the more turns and the more anatomical difficulties with getting that artery open, the more difficulty you're going to have with that stent. And then you just get a big blood clot in that artery and a heart attack, and it's bad, and you end up with pathological slides, which is never really good. Whenever you see histological pictures of the stent clotted off, that person didn't do well.
So Nikki wrote in a question. So after a year following stenting, they should come off as the risks outweigh the benefits?
So in general, that's true. And that's an excellent question. I very much appreciate that. For people who have high-risk stents, who are diabetics, still smoking, and a lot of other risk factors, you can continue dual antiplatelet therapy for up to 30 months. And there's a risk calculator that you can find through the American College of Cardiology's website to figure that out. But in general, yes, I take them at that time off of dual antiplatelet therapy and keep them on aspirin 81 milligrams daily for lifetime. So yeah, thank you. Excellent question. Very much appreciated. Some more pathological slides of stent struts. There's a variety of mechanisms why stents fail. Sometimes they don't oppose, but in about a year, both the coronary tree becomes less inflamed and the endothelium has grown around the stent. So, what you want is a nice layer of endothelialization around the stent struts, like that. And that happens at about 1 year. So, and there is some variability. These are old studies with different types of stents that we make a big deal about these things in cardiology, which stents tend to clot and which don't. But I will say that, we're in the generation of stents that we're using now, they're all perfectly made, and we've learned a lot from that. So the risk of thrombosis is by far less these days. This is a person who had a big anterior ST elevation MI when they prematurely stopped their dual antiplatelet therapy. And this was a published case, but I will tell you that unfortunately I see this all the time. And again, from the primary care setting, I saw a guy who, this was maybe a couple weeks ago, had gone home on one of these really expensive antiplatelet agents, in that case, Effiant, and we gave him, the pharmacy brought him a month, and then he went to the VA to try and fill it, and they told him he couldn't have that medicine, and or they wouldn't fill it at the pharmacy, but they were going to send it in the mail, and he was supposed to get the medicine sent in the mail like 2 days after he came in for a big heart attack because he had stopped his medicine. And so it's just important we're all kind of on this team to try to participate. And there's a variety of mechanisms that we use, but recognition of that patient who's off their antiplatelet therapy and reinitiation of that antiplatelet therapy can be so helpful from the primary care setting or anyone. And so if, for example, let's say they had stopped their antiplatelet therapy for a week, then I would reload them. But let's say they just said, the pharmacy gave you this month of Brilinta or Effiant, and it's too expensive, then I go to Plavix, and then if there's no, week of termination of therapy, then there's no reloading. So if they've been off for a week, I would reload them. And with Plavix, I would generally do that with 300 milligrams. If they're having acute coronary syndrome, I do 600 milligrams. With Effiant, that's 60 milligrams and then 10 milligrams a day. And with ticagrelor, it's 180 milligrams and then 90 milligrams twice a day if you load. And then, so loading dose, then maintenance dose, as discussed with all three medicines. But again, if they haven't been off it for at least several days, there's no need to reload them. Just start them back on their medicine. It is important to note on these newer agents, even though they have mortality benefit over Plavix, that prasugrel or Effiant should not be used in people who've had a previous stroke because there is an increased risk by the trials. And ticagrelor will often cause dyspnea and can cause bradyarrhythmias by its mechanism. And so, so you may see things like heart block, or people say they have pretty severe dyspnea. If they do have dyspnea on the medicine, on ticagrelor, they may get over it in a couple of weeks. If they don't, then that is sometimes a reason to switch them back to Plavix. And remember that the first 1 to 3 months of their time on those medicines, that's the critical time. So if you can keep them on it for 3 months and then switch them, that's ideal. If you can't, then you have to do the right thing by the patient, and you certainly, a slightly better risk of stent thrombosis is not worth a 15 times higher risk of stent thrombosis that you would see if they're just off of any medicine. So you got to choose the lesser of evil sometimes. Okay, so then we put them all together, and that's where we really get bleeding. So there was the WOEST trial, which I guess was from Lancet in 2013, and they compared people on, this is for, so you got a patient with atrial fibrillation that then comes in and has an MI or PCI, and they compared triple therapy with Coumadin plus aspirin and Plavix, or double therapy with Coumadin and Plavix. The primary endpoint was bleeding, and they looked at stent thrombosis, although for sure none of these trials are powered to detect that. And they found that there is tremendously more bleeding on triple therapy. Look at this. A year out, 40% compared to 20% on double therapy. We see less bleeding than that in modern trials, but there was certainly a lot of bleeding. So these days what will often, I'll just say that there's a lot of controversy amongst cardiologists because there is some feeling that, and some evidence that Coumadin and then by extension the direct oral anticoagulants do have some prevention of acute coronary syndrome. And then you think about using heparin in acute coronary syndrome and using anti-thrombotic therapy for the treatment of coronary syndrome and all these things. So, but when you put them all together, there's a lot of bleeding. And so you will often use 1 month of Coumadin, aspirin, Plavix these days, and then go to double therapy. So you use all three for a little bit of time up front, and then cut down to 2 to reduce the risk of bleeding thereafter. We used to go 1 to 3 months, and now where there's a little bit more progress towards only 1 month. There was no difference between death and worse than thrombosis in these groups, but again, it was a trial of about just over 500 people. So, you need lots of data, tens of thousands of people of data, which are actively being accumulated to decide on the right way forward with this. So we knew that Coumadin and antiplatelet therapy was a very high risk of bleeding, and we knew that the new blood thinners seemed to have lower rates of bleeding. So the trial was Pioneer that looked at Xarelto versus Coumadin, and some mixture of antiplatelet therapy. So the Pioneer trial kind of had this sort of odd 3-group design. If you read it, they used Xarelto. If the GFR was normal, they used 15 milligrams. If it was less than 30, they used 10. And they used a P2Y12 inhibitor, which 90% of the time was Plavix, maybe 95%. And there was about 5% of people who would use Epi or ticagrelor. But so most of these people were on Plavix. And just that for 12 months, right off the bat, start to finish. They used the 2.5 milligram strength twice a day, plus dual end. So group 2 was 2.5 milligram strength, which we use for peripheral artery disease now. And I'll talk about COMPASS as time permits, which might not, but the slides are there. Dual antiplatelet therapy for 1, 6, or 12 months. And then they compared that against Coumadin with a similar strategy. And so here's the design. And what you see is that when it comes to bleeding, that group 3 who used Coumadin had much higher bleeding than the Xarelto groups. And they didn't see stent thrombosis even with this 2.5 milligram strength, but again, the trial wasn't powered to detect it. So any major other adverse events were not any different between the 3 groups at 1 year. So if it is true that Xarelto is better medicine to prevent with less bleeding if you have AFib and stents. And generally, like I said, the progress has been a month of triple therapy and then stop it. So let's get a little bit of EKGs in, and then, like I said, we can take questions at the end, and there's a little bit on COMPASS in there as well. So, so again, we're just going to go back to the basics. Last time I did. Actually, yeah, go ahead.
Would you address bare metal stents versus drug-eluting stents?
Yeah, so as I said, bare metal stents generally require 3 months of antiplatelet therapy. Drug-eluting stents can, for sure, you have to be on you should be on dual antiplatelet therapy for 6 months and preferably for 1 year. And almost all cardiologists will say 1 year, because especially in some of the higher risk groups, you still will see stent thrombosis between 6 months and a year. But at 6 months, it's a judgment call. So I think that's, yeah, thank you, and very important.
And one other thing, procedures and surgeries stopping antiplatelet therapy.
Yeah, so again, if it's within a year of their MI or stents, we generally don't. But there's leeway with that. And if they just had some stable angina stents, then 3 or 6 months with bare metal and drug-eluting stents could be reasonable at the discretion of the clinician at that time. So, excellent points. Okay, so we're going to go back to, so we had done supraventricular tachycardia last time, and that's a little more of involved EKG talk. So we'll go back to the basics, which are always important in reading an EKG, and talk primarily about rate and intervals today. So when you have a sinus rhythm or a regular rhythm, you can count the big boxes in order to get heart rate. So if you had QRSs separated by only one big box, then that's a crazy fast heart rate, but it would be 300 beats a minute. 2 would be 150, and 3, 100. 4 is 75. 5 is 60. 6 is 50, and 7 is 40. So you just count big boxes and you go down like that in such a fashion. The EKG is a 10-second strip, so you can alternatively count QRS complexes on the EKG, set thusly, and multiply by 6 to get the heart rate on this EKG. So either counting boxes or counting QRS complexes. Now, if the rhythm is irregular, you have to count QRS complexes because the alternative would be averaging every rate in between that EKG, and I would say that that's sufficiently onerous that you'll never get through your day of clinic if you do that kind of thing. So, so sinus rhythm, and we're going to talk more. Rhythm is so involved. You've got your tachyarrhythmias and your bradyarrhythmias, and that's where a lot of EKG interpretation comes in. And we'll go through all that. But just defining a sinus rhythm is this. You have a P for every QRS, a QRS for every P wave, and an upright P wave in the inferior leads. Also, technically, there should be a biphasic P wave in V1. So the right atrium depolarizes first, and that part of the P wave will be upgoing, and then the left atrium depolarizes later, and that will be downgoing. So this is not perfectly ideal sinus P wave in V1, but if you did have a perfectly ideal sinus P wave in V1, it would be upgoing here and then downgoing, biphasic. But in every other way, we know that this is sinus rhythm. So, so intervals, there's a R to R interval, a P to P interval, and they may or may not be the same. In sinus rhythm, of course, they are the same. There's a QRS duration and a QT duration. So the RR interval is your heart rate, and the PP interval is the same in the sinus rhythm. And so a heart rate of 60 to 100 is considered normal on an EKG interpretation. A QRS duration should be less than 100 milliseconds. 100 to 120 milliseconds is an intraventricular conduction delay, and above 120 is a bundle branch block, or could be a nonspecific intraventricular conduction delay, but generally a bundle branch block. The QT interval should be in the context of the RR interval, which is a corrected QT or QTC. And generally, when you correct the QT interval, which we'll talk about in a different talk, that should be less than about 460 milliseconds. Very short QT intervals also could be arrhythmogenic and perhaps less than 400 milliseconds. So, that's generally going to run 400 to 460 milliseconds. If you have a bradycardic rate, then you don't correct it, you just take the raw QT interval. QRS and P wave both have axes, and we'll review electrical axis in a different talk, but you may look for P waves to go in a different direction. So, that's pretty much it for intervals. So Sharmisa she always sends me, like I said, some fun EKGs, and I think these were actually super great because they correlate really well with the rate. So what we have here, just to kind of start out, is a narrow complex tachyarrhythmia. So when you have tachyarrhythmias, you have sort of a branch point. You have wide complex tachycardia and narrow complex tachycardia. In wide is ventricular, could be supraventricular, and narrow is supraventricular, some family of supraventricular tachycardia. And so we're not going to go through all that because we just did last month and we will again in the future. But I will say that if you look at this thing, if you march out the QRS complexes, it is quite regular. So you can count boxes in this situation. You just have to find a QRS complex that falls roughly on a box. And so if you look, this QRS complex is right around that big box line, this darker red line. And there's 2 big boxes, so it's right around 150 beats per minute. It's just very slightly over that if you see there. So you can do it that way. Or you can count them 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26 times 6. So that's 120 plus 36, 156 beats a minute. And so they're both, either way is quite acceptable. Just for interest, there's probably a short RP tachycardia, and a lot of the time when you see this type of arrhythmia, there's no definite P waves, and it's a very, and you have this type of supraventricular tachycardia, it's AVNRT, and in this situation you would want to give adenosine, and if that cures the arrhythmia, then you've solved your problem and you know it's AVNRT, and if it unleashes a flutter wave, then you have atrial flutter. And so, so 155, 156 is the rate there, and it's a supraventricular tachycardia. So now this is the opposite end of the spectrum, right? And so there is a little bit of irregularity here, but let's just count our QRSs because you know, well, we can do it either way actually. So 300, 150, 100, 75, 60, 50, 40, 30, 20. So it's, you know, just above, looks to be just above 20 beats per minute, except that you have this one little probable PVC there. So 1, 2, 3, 4, 5, 6. 6 times 6, of course, is about 36. So, you know, it's about 30 beats a minute, this very slow rhythm. And I'll just say, you know, not having reviewed our bundle branches, and this, it's wide, and you have a left bundle branch block morphology here for the most part. You know, ideally it'd be upgoing in V5 and V6, but it's wide and it's deeply downgoing in V1. It's upgoing in 1 and AVL. So you have a left bundle branch block morphology in these complexes, but not this complex. And furthermore, so that's the ventricular rate. And what we haven't been doing, since we haven't had any atrial activity, is seeing if there's an atrial rate. And there's no, I see no atrial activity anywhere in here. And so what, in summary, I think this is a PVC, and you probably have a junctional escape rhythm. So a sinus rhythm, I said, I'm sorry, a ventricular escape rhythm. A sinus rhythm is 60 to 80 beats a minute. A junctional rhythm is 40 to 60 beats a minute. And a ventricular rhythm is generally 20 to 40 beats a minute. So this looks like a ventricular escape rhythm, and that's why you most likely have a bundle branch block. And I bet if they're in sinus rhythm, they are going to have a narrower QRS, most likely. They end up with a pacemaker, most likely, in this situation.
It's underlying AFib.
Yeah. So, yep. So, so there you go. AFib, 6 sinus syndrome. We nodal block them down, and then they have this, and then we put a pacemaker in. And, you know, sometimes we have to swerve a little to find the right course. And then lastly, this is another really fun one by Sharmisa. And so, again, we're just gonna do, rate, and then we'll go to the rest after that. So it's pretty regular. So always look at the rhythm strip when you're evaluating rate, and that usually will be standardly 2. If you have EKG software available, you can switch that around. If you can't see good P waves in 2, then you can make it 5 or 6 or V1. But in any case, so we have a QRS here, 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 here. This looks like, you know, so this is a premature QRS, and then here, 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 here. So we can count them 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 66 beats a minute. We can look at this. Remember, there's 1 extra, so the normal V to V rhythm is going to be just less than 66. So we're just about on that line and that line. So 300, 150, 100, 75, 60. So right around 60 beats a minute and 66 with that extra beat. That's the ventricular rate. But when you look at this thing, you got a P wave and then a QRS complex. And remember, sinus rhythm is a QRS for every P and a P for every QRS. So there's this thing right here is a reasonably clear P wave with no QRS. And so this is 2-to-1 AV conduction. You don't know if this is Winkie-Bach or Mobitz 2. Usually you want to guess Winkie-Bach because Mobitz 2 means there's balanced infranodal conduction system disease. But in either case, this happened on a treadmill, and that should not be the case. Your AV conduction should be more rapid. So I think this person also ended up with a device.
Yes.
Yeah. Okay, well, I ran a little over time. We started a little late. I very much appreciate your attention. I want to take any questions as they arise, and happy January.
Okay, thanks.
Yeah, good luck, and we'll again review lipids and then also statin myalgias in future and previous lectures. So, all right, everybody.
Thank you.
My pleasure. Take care, and Happy New Year.
See you next month.
Happy New Year.